Yeah, so I've started this presentation by, as much as anything, kind of going over how I ended up in this career, or even feeling like I have any business talking about digital health at all. So that resonates really nicely. So yeah, this beautiful picture here, this is one of my favorite places to stand and breathe and practice gratefulness. So it's just a short bike ride from where I am now. I'm in the traditional country of the Awabakal and Warramai people. So that's in Newcastle. And I want to pay my respects to elders past, present and future, and recognise the past atrocities against the Aboriginal and Torres Strait Islander people of this land. So they continue through strength, resilience and pride to practice the world's oldest living culture and nurture country. So yes, I'm Gillian, and a bit about me and my background. I'm queer, I'm a bicycle riding, proudly disabled and chronically ill physiotherapist. All those bits are important, and we'll get to why. But I'm a physiotherapist, but now a communicator, working in digital health and rehabilitation research. So I'm also really tired of the reductive way that we think about and value disability. So I'm going to tell you a story. And like all good stories, this one's going to be inclusive of all the elements that make a good story. So some sex, drugs, rock and roll. Feel free to laugh because it's really helpful. Human rights and bicycles. So this is me. It's got a super slick looking racing cyclist. And the story is going to talk about my originally accidental and now really varied career in healthcare. So we'll talk about change and finding your shared purpose so that you can make sure that whatever you are doing has impact. And yeah, because I have this platform here, I'm going to take every opportunity to basically talk about how we have to include health consumers as stakeholders and as colleagues in our work in digital health. And then we'll also look at problems like ableism and discrimination. And I want to remind you how the health consumer, and you brought this up before, Meredith, I was really pleased about it. We're not one homogenous people. So if you've met one of us, you've just met one of us, as they say. So I want to discuss intersectionality as well, which means what happens when the different layers of social factors and identities combine their powers and make you or make a person more likely to be marginalised. So back to this picture of me on a bike. Here I am as an example, not nearly disabled, but a bisexual, separated mother, and the worst shame of them all, a road hogging cyclist. So I'm not like that anymore, though. That was 14 years ago. But then already I was living as a physiotherapist and with a genetic connective tissue disorder called Ehlers-Danlos syndrome. So it's a condition where the structural matrix in the connective tissue that holds all my organs together is more fragile than it should be. So for me, my joints sublux regularly. I've got osteoarthritis, chronic pain, muscle weakness, gastrointestinal problems, incontinence. My body doesn't regulate blood pressure and temperature very well. And a few months after this race, I got sicker and I got diagnosed with an unrelated autoimmune peripheral neuropathy. I had to stop racing my bike. And basically my body's natural immune system is just way too spicy. It attacks the nerves between the brain and the rest of me. So, I mean, you're mostly medical. You kind of know some of this stuff, but I think we really forget that people can be living with lots of stuff going on and you wouldn't be able to just tell or even really be thinking about that just by looking at them. So with these couple of things going on, I mean, the nerves, they run everything in the meat suit. So it affects all of my body systems and it's progressive, degenerative, and the excellent medical treatments that I have that are slowing down how quickly it's getting worse, they just take up a lot of time. So the next slide in this gallery of bikes that I'm going to subject you to this morning, this was taken about 6 months ago. So this is my long wheelbase electric assist cargo bike. It's my main mode of transport. It's my joyride. And I've got my kayaks hooked up to it. I put a picture of my son, Jimmy, in here because it's easier to get people to remember that you matter, you know, as a female disabled person if you're a mother. And now, when we talk about disability this morning, I want to use both first-person language, person with a disability, and identity-first language, like I'll call myself disabled. Both are valid, but if you're speaking with people with disability and you don't live with it yourself, it's probably better to use person-first language. Just don't correct the disabled person, I guess, on how we choose to use language to describe ourselves. And please don't use euphemisms like handicapable or, diffability. Like that language, it's not specific, and it infers that disability is something to be erased or ashamed of. So back to the story. I'm also going to share my opinion on how to figure out if you're doing the right stuff in your career and what I think is important in leadership. And we'll also include the Spice Girls. So that's the summary. Now, I mean, we're going to have the Q&A at the end, but if you've got questions or you just want to note down something to talk about later, use the chat, use the emojis, or just be rude and interrupt. That's fine. It should be more fun that way. So for now, and if you've seen me speak recently, you've probably heard a little bit of this stuff before, but I wanted to cover it again and bring the story to April 2020. So in this video here, I was standing outside the hospital waiting for an Uber to take me home after having an immunoglobulin infusion. So that's a bit about drugs. Sorry, there's not anything more exciting coming up. But on this day, it was about a month since COVID in Australia had put the word unprecedented in the title of every news story. It had been bad, but even though we were in the thick of it, on this particular day, I'd started to feel really hopeful, like things were going to get better. People were listening to scientists, and everyone who'd ever seen a sewing machine in Newcastle was sewing masks. Now, I've got a couple of other health conditions too, just because I'm lucky. But for expedience, like for me to stay alive, rubber side down, I have to go to lots of medical appointments, and it's at least one per week. And it takes up so much time. I've got to travel to many of them. And even though I live in the city, obviously it's very time consuming. It takes a lot of energy. And I also work in healthcare research, as you know. And over the past 10 years, I've been doing everything that I could as a clinician, as a researcher, as a clinical leader, to try to get the health system to use more phone and video calls for the healthcare appointments that you can use them for, so people didn't have to waste all of their lives in traffic in hospital car parks and waiting rooms. And I wonder if you could use the thumbs up emoji in the chat, or just pop something down there if you've had a telehealth appointment yourself as a patient, or if you deliver one as a clinician. I just want to know how much you're going to empathize. I nearly said emphasize. So while you're doing that, I'm sure that you've ended up having one. Yeah, brilliant. So as a quick aside, I keep this selfie of Dr. Swan and Professor Brooks and myself kind of at hand for street cred when I think I might need it. And on this day when it was taken, I felt like all my career aspirations had been achieved and I could retire early. But yeah, it's got some relevance because Dr. Swan and I started this telehealth policy think tank in November in 2019 with a karaoke rendition of Simple Minds, Don't You Forget About Me. This was before the pandemic, it's 2019. And that was 22 years after the first time that I'd experienced having a video call. So then I was at a summer science camp for high school girls in Wollongong, and we had a lecture on how video calls were about to transform the way that education was delivered. And that was exciting. So then 22 years later, I was flown to Brisbane to think tank in person and meet in person with a room full of other people in person from all over the country to think about how we might transform the way that healthcare was to be delivered by being the driving force behind rapid at-scale telehealth implementation. Like we might have been if it wasn't for the global pandemic stepping in to be that driving force behind rapid at-scale telehealth implementation. And look, largely it was great as a patient to be able to have access to telehealth appointments. And the telehealth appointments themselves, they worked fine mostly, but it was really quickly obvious that patients, particularly disabled and ill people who were most frequent users of the health service, they hadn't been consulted. We hadn't been consulted in working out the piece about how the user is supposed to navigate this new digital healthcare approach. Certainly as a clinician, it was clear that nobody had consulted with me about how we were going to use this thing and make sure that it felt like it was straightforward for people. So we ended up with complicated and convoluted approaches, processes for linking in with all the different systems. And then you'd get unfathomably complicated like letters about in the mail explaining that you'd want a video call appointment, and then you'd have all this admin like to phone and wait and email and double check around the inconsistencies of all of that. So telehealth ended up being a lot of extra work. So yeah, this is 2020, and we're thinking telehealth was a new approach for most everyone. In many cases, you'd get an appointment and the reception person would say, look, the physio is going to send you a link before your appointment. So this was one of mine. How was any user supposed to know how the health professional was going to video call them, or what device they might need, or how to set it up, or which speakers to use, or which microphones, or, you know, will you need someone to help? Will they call on time? How will I know if I'm in a waiting room? Like, I had all these questions and no one seemed to understand why I wanted to ask them. And at this point, I've been using telehealth sessions in my daily business as a clinician since about 7 years. So I'd run calls on a few different platforms to different various personal devices that patients had. I'd run exercise classes from home by telehealth to regional hospitals, and sometimes using fancy video conference room hardware, you know, when we didn't just have little webcams and Zoom. And I'd even set up a hybrid cardiac rehab-like program that linked physios with personal trainers and people with mild stroke in gyms by telehealth, and that won a translational research award. So there's absolutely no way that I should have had any problems as a patient accessing telehealth. But like, remember how we told people that it would be the old people and the people with poor health literacy or the poor digital literacy too that would struggle with the telehealth? So I'd had so much trouble accessing my telehealth appointments throughout the pandemic. So it would happen a lot that you could try and phone the reception desks of various clinics and practices, and you'd risk waiting on hold for ages, and everyone was so busy. And the reception staff didn't know the kinds of practical details that you'd need for these appointments. Like here, I'd booked a telephone appointment using my GP's online booking system. And I got this SMS reminder telling me to expect a phone call from a private number at the appointment time. So that should be straightforward. Hang on one second. So the other thing going on there was I was working at home, and I thought, great, I've got this telephone appointment. I should have time to ring my project manager while I was waiting on phone. And before you think, like, geez, just relax and have a cup of coffee and just wait, this is where that intersectionality thing comes in, because I'm a single parent and I've got several different health problems. So for me to have enough time to work, to earn enough money to pay for life and to pay for the medications and my healthcare appointments, I just can't afford to take time off work anytime I need to wait for an appointment. So I thought, brilliant, telehealth, straightforward phone call. I'll see the incoming call coming from this private number when the doctor's calling, and then I'll be able to jump off the call with the project manager, take the doctor's call, have my appointment, and feel smug and accomplished. So at this point in my story, I need a narrator to say, but Gillian did not receive an incoming call from a private number. Rather, she received a sneaky text message. So I got this text message, and of course I just ignored the little pop-up on my mobile phone that said, new text message, because I was waiting for a phone call. So 20 minutes after my appointment time, I got off the phone to the project manager, I made myself a cup of tea, and I sat down to resume waiting, and then I checked my text messages, and I'd missed this text. So at that point, it's 20 minutes late, I clicked the link and I was taken through to this screen here, which says that I've missed the appointment. The consultation's finished, and I was devastated, like quite stressed, and I really needed this appointment, and I tried to make it work and use the telehealth opportunity, but I'd been begging my doctor for this for years at this point, so it felt like the stakes were very high. And I didn't want to take sick leave for appointments anymore. So then I had to call reception again, have a long wait, so that's cognitive labor. I had to apologize, that's emotional labor, to rebook, so I'm booking more time away from work, which is going to cost me money. It's going to cost me my reputation for being reliable at work when I'm supposed to be. And all because the admin processes gave me inaccurate information about how to navigate this digital interaction. So you're thinking probably at this point, like, what a moderately sized inconvenience, right? But what does this have to do with disability inclusion or discrimination? So if we have a look at this one-off inconvenience situation and then scale it up and consider it and the impact in the context of my real world life, between February and November in 2020, which is the last time I bothered to measure, I had to go to hospital 8 times. I had 59 other outpatient health appointments because I got some bonus illnesses in 2020. 31, of those were offered by telehealth because of the unprecedented telehealth revolution. And if we just estimate that I wasted about an hour on admin rubbish for each telehealth appointment, that's kind of conservatively 31 wasted hours. I don't want to spend heaps of time on this because some of you will be bored if you've seen it before, but I've added up the amount of time it takes within the context of my real life routines. Yeah, end-to-end testing from the provider. Yeah, that would be nice. And you've all got the opportunity and responsibility to do this stuff better, and I'm sure you already are. But the reality is, even though we're working on so many amazing approaches and we're using new tech and we're doing things that are really innovative, so much of the very basic stuff is still like this. And the context for people who are chronically ill is just that we're really, really busy. So 25% of my total waking hours have to be spent on health appointments and self-management activities, the way that things are organized now. So that's quite a lot of hours per year, averaged out across the year. So that included time in hospital and all the other stuff. Yeah, I mean, this is stolen time, basically, if we've got poor logistics, before I even worry about whether the rest of life, like leisure or social activities, might be accessible to me, and then try and find out enough information to decide whether I can be bothered with that or not. So let's not get too, this is going to be hopeful, and we're going to work out what to do about this. So we'll go back to the great telehealth scale-up solution of 2020. So no one responsible for these tele projects realised or even cared really that these annoying miscommunications were causing a compounding impact for heavy system users like me. So they knew that the text messages weren't quite right, because when I'd say, oh, I got this text message, every time they'd say, oh, we know, but it's kind of wrong. We can't change the wording and we're too busy. We'll get to that. But for users like me, the impact of this was massive. And no one was measuring or even could think to understand the true impact of it, because generally no one working in these teams is disabled or chronically ill. And that means that people designing the systems, workforce, just lacks this critical culture value knowledge about how things really are for disabled and sick people trying to access healthcare. So one of the measures chosen to demonstrate the success of the great telehealth revolution was hours of precious time saved in transport. So I saved lots of transport hours, wonderful, but you'll remember I also wasted an extra 31 hours on silly admin. So this is going to look more like a net benefit of about 15 hours saved in that 10-month period. I'm not upset about that, but I could have saved a whole damn week. And this is kind of how we decided to measure outcomes of telehealth with things like transport. And unless we're engaging end users in deciding how to measure the impact of a new intervention, we're just not going to get it right. And you'll be aware that here, I haven't even gone there yet about how people with cognitive or communication disabilities, or people who need to use an interpreter or so on, would have had to use loads more resources and supports just to deal with the cumbersome admin situation before they get to their appointment and try and manage or attend that. So, yeah. It's just, I like it. I know I've talked about my frustrations with telehealth implementation a lot, but it's a really clear example of where a potentially great solution that when it was designed, it had considered medical aspects, considered technical aspects, but it just didn't understand the real life routines, priorities, and communication needs of the humans using them. So look, it raises some questions for me. Why does no one value our time and lives? Question one. You're probably thinking, why am I still here going on about my personal beef with telehealth instead of talking you through what you have to look forward to in a career in digital health? And why haven't we reached the sex part of the story yet? So here's that bit. Whoop. Now, I'm not trying to sexualize myself at 10 a.m. on a Wednesday morning in a professional setting, or even sexualize disability as such, just trying to use a bit of humor and celebrate my authentic self in a clinical setting to humanize disabled people. So this was in February 2020. I was in hospital having an operation after some sepsis to ease me slowly into the pandemic in great shape. Now, this hashtag hospital glam was started by Carolyn Geary. They're a queer disabled artist, and they happen to have the same genetic connective tissue disorder as I do. And hospital glam has become a social movement that seeks to take the shame and stigma out of disability and chronic illness. Now, Gehrig said in an article in 2015, "The act of taking photos reasserts my agency over my body in a space that's otherwise uncertain," she said. "Sharing them transforms it into a way to normalize the experience of living with illness and hopefully lessens the stigma of taking care of yourself." Now, in 2015, this was radical to me. It's been 8 years since-ish. And I don't feel like we've come very far in understanding that disability is a normal part of human existence for 20% of the population. So I just want to share one of my favorite mic drop moments of all time, 2018 tweet by Jennifer Lee Rossman in a reply to a tweet by a person from here on. We're going to refer to them as Old Mate Ignoramus. So this is the tweet. "Disabled parking should only be valid during business hours, 9 to 5, Monday to Friday. I cannot see any reason why people with genuine disabilities would be out beyond these times." And so Jennifer Lee Rossman drops it. "We're disabled, Daniel, not werewolves." And this is just it, isn't it? Thanks for turning your mic on to laugh. It's hardly Daniel's fault though, right? That he thinks we scurry home by 5 p.m. because you don't see disabled characters. Oh, sorry, what was that?
I was like, that got some very good laughs in this room. Sorry, we had it on mute for it.
No, I love this because, yeah, it's a joke, but this is how ableism plays out in society, not just in healthcare, but it just amazes me that it does in healthcare, because healthcare is full of disabled and ill people. But in mainstream media and society, you don't see disabled characters in film or television doing, like, you know, hot girl shit. Or you don't see them going to a band unless the story is all about the character's disability or how sorry we all feel for them. And look, I share a sincere solidarity for my friend in this photo aid who's standing in the front row of a concert loving himself sick. But he's like all disabled people. He's experienced grief and loss and anger around what he's lost, and he has to endure ongoing trauma and lots of rehabilitation. But what makes me furious is that he lives with a mobility and a vision impairment, and he has to be confronted with this kind of rubbish when he turns the corner, when he's just out walking, trying to go to work or to anywhere, without any word of warning in advance to expect it. This is what life is like for people who are just constantly excluded from society. Like, we don't routinely make sure that everyone knows about access issues in advance in healthcare. People have to, like, literally risk serious injury or deal with huge inconveniences with detours. People wander around our health systems kind of in constant fear of the next exhausting hurdle that other people have never considered, and it's because of ableism. So I've got a really short amount of time to cover the Spice Girls before we talk about digital health careers altogether. So yeah, now as I'm getting older, I'm learning how to get rid of my internalized ableism and start to value the resilience and the high-level problem solving skills that I've developed as a direct result of having to hack through this life that's designed for abled people, non-disabled people. So I've started talking publicly about my lived experience of disability, which felt really scary and uncomfortable and maybe a bit narcissistic, to be honest, to start with. But I've realized that it's important to do that every time I feel like it's safe to do so, because I want disability to be front of mind in decision-making tables at councils, so roads don't end up like this without any warning, in healthcare and in research, in politics and in the arts. And I also want the next person, and there's 20%, so a couple of people here probably have chronic illness or disability, or it's coming, it's just a normal part of life. I want people to see that you can be successful and unashamed and included. So I want disability to be normal at work, normal at play, and I'm just not hanging out with ableist people anymore. Yeah. So I want to chat, but just remind you that we're not just excluding a tiny minority of people if we're thinking about disability. I mean, particularly in healthcare, because people are overrepresented, but only 48% of working age disabled Australians are employed, as opposed to 80% of people without a disability. And 41% of employed disabled people have part-time work, compared with 32% of those without disability, which is a problem that's called ableism, basically, in discrimination. And the reason why it's a big problem for us is because that contributes directly to health inequities. So the last 2 years, I've been able to work full-time plus some, just because my healthcare has been more convenient, for no other reason. I was not too sick to work full-time before, but I've missed out on career opportunities and super and whatnot, just because of inconvenient healthcare. So it's just something to think about when we're creating workflows, when we're designing new health approaches, like who needs to be in the room? Because have I considered the impact on them in their real life? Yeah, I've got a few pictures of me doing physiotherapy things, and I can talk to different bits about my career and kind of how I just ended up in digital health. But I wonder, do we want to have a chat?
Yeah, I think it'd be great to just have some thoughts about what you've talked about so far. And I don't have a disability, but just my minor interactions with the healthcare system have just been so frustrating over the years. And then watching family members try to navigate or be ignored and be told that it's in their head, and all those things that we hear about in the news happen to so many people. So I just want to echo that.
Yeah. And we've got this, I mean, you're you're wanting to be involved in digital health, and you're wanting to be leaders. And so you've got this big responsibility, but this enormous opportunity to start to use data and to set up processes to address these problems. It's just figuring out how to be really inclusive about that and work out who is not being included every time we do something. Because I certainly do not understand the needs of all of the users of my health service. I don't live their life. I'm not abreast of all of the research looking into different ways that people are left out. But it's trying to figure out, well, who needs to be at the table each time we have a project.
So I thought I might just pick up on the theme of time that you drew out, because, having... the part I usually play in research is sort of the resourcing and thinking about how this will actually work in real life. And the rate limiting step I've found is time for everyone to actually spend doing these things well. I mean, every time I talk to a clinician, they're really busy. As you say, the patients, they're really busy with their normal lives. And so I just wonder if that might be a little bit of a theme to talk about, is how we create that time and space, when we've also got projects that need delivering and, health systems that need improving. How do we do, what's your experience in the way that these things can be done in the sorts of timescales that improvement projects run on?
That's a really good question. I'm going to skip across and put some points in the background actually while we talk about this. So yeah, how do we do it in time? We need to have the right person, the right people in the room, and the right people in our teams right throughout the process. Every time we're going to seek to do anything that's quality improvement or to think about a new intervention, I think it's really important that we figure out whether we're answering the right, we're solving the right problem. Do we have the right problem to solve? In real life, you often don't get that privilege, do you? Because you're kind of just given some money for a thing that's come up, or there'll be a priority, and we try and do something because we want to do something. But for me, the most powerful way to make things take less time is to make sure that we create inclusive, accessible workplaces on the one hand, and also have invest in continual engagement with the community and with the end users of our services. So invest in figuring out a way to do that so that there's someone or some people who are approachable to the public. So for us, and I mean, I've just got up here of thinking about consumers, which people do you have in the room? That can be people with lived experience of a condition, or you may be talking about the public or the community, or you're talking about clinicians often when you're trying to get the right consumers in the room. But people with lived experience, they bring their experience of the condition, and they bring access to other stakeholders and networks that aren't generally available to the rest of the team. But what they usually don't bring is organizational knowledge or kind of any background in research or health often. And we need to include these types of people who don't know anything about the health system from the inside. But if we just call on people when we've got some focus groups to run, or when we need a consumer for a grant, we just can't get much value out of people. So I've said a few things here, but what I'm getting at is that I feel like it's important that we invest in continuous engagement. And I mean, some things that I've done, I'm working in stroke rehabilitation research, was to employ people into positions. So I have a research assistant who's got a science background, but she's a stroke survivor. So I created a targeted position because it's so useful for us to have her lived experience expertise as part of the knowledge. And she then is able to pull in through her networks people who are going to be most appropriate to work on something, because she just knows people and she has these relationships that the other clinical and research team members haven't had the time or the business actually in creating. So rather than having lengthy consultations every single time you need to do anything, just with some different expertise in the room, it's easier to think, okay, what do I need? Do I actually just need the opinion of a couple of people on a thing, or do I need a comprehensive co-design process? And yeah, does that make sense? Kind of, we've just got to be more inclusive, and then we're going to save a lot of time.
Yep. The other thing I thought it would be interesting to pick up on, was your telehealth experience and just the confusing messaging. And I guess, that's another, lesson I've learned in consumer engagement is investing in the resources, that there is someone who can, make sure that meetings are scheduled at the time that suits the consumers, who can look after the parking tickets or call the taxi, or, and to me, it's about having skills is probably not quite the right word, but just, the ethos in which you approach your work is to put yourself in the other person's shoes, to, imagine their experience and smooth it as much as possible. So, and I'm sort of thinking, you could see that, the reception staff were clearly not able to do that, setting up a telehealth appointment. So is there anything you wanted to sort of add in that vein and your experience in terms of, where you invest in consumer engagement to make sure even your consumers who you're involved in your research projects have the best, so I guess it's about reducing the barriers to involving consumers in your research.
Yeah. There's probably a couple of parts of that.
Mm-hmm.
And I've got a couple of slides to help me answer this properly. One of the things I invest in to make sure that I'm abreast of more of this stuff, because we don't have time to do a literature review on what are all of the access issues for this specific population that we've realized isn't included in our service every single time. We don't have time to do that. But I spend deliberate time in patient groups, not in a weird way as a lurker, and you need to be respectful and responsible in the space. But there's groups, there's some groups I'm involved in, the disability groups and chronic illness groups. And I mean, I belong in the space as a patient as well, but I'm involved in other stroke community stroke support groups. And I just have relationships with people, and you just kind of absorb this culture, value, knowledge, and you're thinking then of things you wouldn't have thought of, because people will mention this kind of stuff regularly. And then I want to add, I was jump back and forward here, but like, you can't pretend that you know what it's like. So it's not for you to be the voice for the consumer, but you do need to spend time with consumers in a way that is different to just having them as a research participant, or like you don't know what your patient's life is like when you're a clinician, because you only ask them questions that are relevant to the things you think you can help to fix. Like, it's different. You need to be in spaces with end users. So if you're not a clinical person and you're trying to work on changing things for clinical workflows, you just have to be spending time with clinicians, just listening to them in a day-to-day, in an informal way. That's the biggest time saver for me, because then when we think of something, I will firstly go, oh, wow, actually, no, I've heard such and such say these things. Are they problems? I can then quickly verify more specifically with research and pull those people in who I already have relationships with into a project team, and then be really specific about what we're trying to do and what the person's role will be. You also mentioned making sure that everything is accessible, like most accessible to the health consumer. But I think, and I'll just push forward to the slide, like, yes, don't be the voice for the consumer, but you actually also, if you're working in this space, you do know lots of stuff and you should know people. This, I was going to talk about imposter syndrome, but that's fine. We're all comfortable with that. You need to be, and I feel like this is good career advice as well as good advice when setting out a plan of how to work with anyone in a team, but particularly with your consumers. You want to be deliberate in what you're trying to do and communicate that really clearly. I like the word ubiquitous, but it just means be kind of everywhere, but everywhere that you need to be. You do need to not just be in clinical or research spaces. If you want to actually understand what life is like for people, you kind of need to seek permission and figure out how to be in other spaces as well, so that people know and trust you and you are approachable. If you call a stranger who someone's recommended as a consumer representative for a role and tell them about your project, and they respect you because you're a professor or a doctor or whatever it is, and then you say, oh, by the way, do you have any kind of problems that'll be like things that'll make it really hard for you to take part in our thing, like, you know, any impairments or disability stuff? The person is not going to be prepared to share that with you. And it makes it a really difficult conversation of, or how do I make sure that I'm putting meetings at the right time? It's much easier if you have some relationships with people to start with, and if people can introduce you to strangers if you need to work with them, and just help you to understand what their needs are. So you're just trying to think about it from, okay, if I was getting invited into a team, like for me personally, I have to do quite a lot of stuff in the morning so that I don't end up in pain through the day. So if I come into a team that feels like there's good, respectful relationships, someone's introduced me, and I can say, I'm not going to be able to participate in morning meetings. It's not, 10 o'clock's fine. 8 o'clock is not fine as a health consumer in a team. But nobody's asked me to spell out all the detailed reasons why, because that's not relevant to the conversation. You're just trying to explore what are the access needs so that the person can participate. And you've told them exactly what their role will be. Like, you're not just inviting someone in a team to be the voice for someone. You've got a specific role. They're bringing knowledge or expertise about something. We're going to put meetings on at times that they work. We're going to make sure that, we offer different accessibility things that they might need. And I think it makes it much easier for people just to speak up and tell you what they need. If you've defined, like, you've been purposeful about it and you've defined what kind of a shared purpose is on the project, because then people will tell you and people will speak up and give you good and honest information. Yeah. I've kind of developed a shared purpose statement for myself, if that doesn't seem weird, because I've ended up in a career that doesn't look like anyone else's career, and I just didn't know whether or not you should say yes to the next thing or no to the next thing. So I kind of try and figure out career-wise, does this thing align with my values and what I've decided my shared purpose is going to be? But then within the way that you conduct yourself and the way that you organize teams around projects, if there's a shared purpose and it's clear what information we want to share with each other, what values we want to share with each other, that stuff just comes out really easily, I think. Yeah.
And again, you know, those things take time and time to have those conversations among the team. And, you know, I think it's just emphasising the importance of these are the things that it's worth investing your time and effort into as you conduct any project. You know, everyone's keen to get going, and, you know, there is that place, I guess, you need to pause and spend a bit of time, you know, building that team in the inclusive way that you've talked about.
Yeah, and you get better at it. And it doesn't mean that every single person on the team needs to know everything about your consumer member. Just everyone on the team needs to understand that we're going to work with this person in this way. Mm-hmm. Someone's got a good relationship, and it's not dissimilar to if you brought the director of the Medical Research Centre into a meeting for a reason. You would prepare them in advance, give them a bit of context, help them to understand exactly why you'd invited them to be there, and then try and be quite efficient with them about their time and make sure you got value out of that conversation. And we should just respect all of our team members in a similar kind of a way. I think with practice, it doesn't need to take a lot of time. And the other people you work with will get used to you saying, we don't hold afternoon meetings because they don't work for people who have fatigue after, with cancer treatment. Mm-hmm. And then you don't have to say, oh, but it's really not great for Joan. And do you think we maybe could? It's just no. That's when can we organise it? Because it's not, the meeting's not accessible to everyone otherwise. Well, I made a training package together with a couple of other researchers and survivors of stroke that is stroke specific, but and I can put the link to it in the chat. But we covered a lot of this stuff of how to have conversations about access needs and how to make sure that people, that you've been prepared and you've given people enough information about the context, how your organisation works, what the intended aims of your project are, so everyone's expectations are set. It's a 40-minute online free training package. I think it's worthwhile doing, and I can say that because I worked with other people who brought great expertise and experience in. But we really focused in this one, even though it's about stroke, on just how do you manage teams and design accessible processes for involving consumers in clinical research trials. So you could have a look at that.
Fantastic. Love a good resource that's available to everybody. So,
I wonder, Go ahead.
Oh, I was just going to say, should we open it up to the rest of the room? I've been hogging the questions. So go, Wendy.
Well, I was just wondering what the fellows are thinking about this, and if there are particular, how is this making you think about your project and where your project intersects with the patient and how the patient might have needs that you may not have considered that you could think about? Anyone willing to share that?
I feel like it's caused great thought. There's a fair bit of thought involved. What about here in this room, in this space? We've got... Yeah.
Sure. I don't think I'm on the camera. Hi. Not directly with my project, but thanks, Gillian. That was a great summary of how to make sure that your research and your healthcare design is inclusive. We have exactly the same problems that you've described. I work at 3 different health services, and it seems that there's a ad campaign at the moment from, I think it must be the Australian Digital Health Organisation or Association or whatever it's called, and the ad campaign says something like, your doctor can send scripts to your pharmacy directly. And at none of the places that I work is that possible. Two of them being public hospitals or places where you'd think it would be possible. So, there's you're sort of talking about a mismatch between communication and expectations and reality. And so I think, text messages having wrong information and so on is very much the norm at a few different places where I work, and it's incredibly frustrating for patients. I mean, let alone patients that have care responsibilities or increased demands upon your time, as you mentioned. So I was wondering, and perhaps there is no simple answer, but is there anything that, as a clinician with no direct ability to influence, or at least seemingly no direct ability to influence, wording of text messages, for example, or the specifics of the problem, in addition to obviously advocating and so on, do you have any other advice that, as a frontline clinician, that things we might be able to do to fix those issues?
Yeah. Did you see me go, oh, because it is all of our business. Like, the reason why the text messages are just accepted as normal by our health services is because we've all just accepted that it's normal. And I know that we can't solve every problem. Like, I have worked as a clinician, and I understand that you cannot solve every problem. It's impossible to, and sometimes it's really not your business to. But if you're working with people and they're repeatedly telling you that these are big problems, we just have to take some responsibility for that and figure out, like, are we investing in the right areas with our time and efforts? Because sometimes there can be these low-hanging fruit problems that users will tell you about. And for clinicians, it's so annoying when the person wants to spend 5 minutes offloading about the administration stuff in your appointment time when you only have a short time with them and you've got to get to the point. It's kind of soul destroying, right? So we need to be communicating these things up back to, it would be better, I think, if we didn't have IT departments and we instead had, I'm really excited about the work that you're doing, Wendy, and with the Centre for Transformation of Health, because we don't want IT departments in hospitals. We want like living labs, and we want clinicians to be able to, like they have in Scotland's NHS Near Me approach, clinicians and the users were actively encouraged to complain. And there were some resources dedicated to taking on that constant feedback to figure out what were the pain points in the process. Because particularly if we're looking at stuff that we're trying to translate things that have worked in research, that have good outcomes, it's really important to know where it's not going to work. So I'm not sure if I've answered your question directly, but how do we do it? We just have to keep, that thing about being ubiquitous. We just have to keep saying it, and to people to all sorts of people, and not be the voice for the consumer, but make sure consumers are included in roles, and find budget for them in your work, so that people who aren't like expert consumers or have the resources maybe like I do can take time off work, or can actually come and participate in these processes, and also tell the people who can change the text messages about the actual impact it's having. It's not just an inconvenience. It literally means that you might lose your job because you've had to make all these extra appointments and no one trusts you anymore that you're reliable.
I wonder if, framing it, and it'll be interesting maybe for everyone to kind of reflect on, part of this is about framing all the different dimensions of your practice in your job. So you have practice as a clinician. We all understand what clinical practice is, but you also have your research practice, your practice in the way that you, engage with, different project groups. And I think I wonder if there's something about thinking about all those different dimensions of your everyday practice and how you work that feeds into that question, because even though it's not directly to do with your clinical practice, it is to do with your work practice. And
it's impacting on how you are able to deliver your clinical care. I think that helps for me if I'm thinking about what's my purpose working in healthcare. Like, yes, I want to do a good job as a clinician. So I don't want to end up, and this has been a stress for me, in a kind of a wishy-washy professional role where I just, you know, talk about heartfelt things as a consumer. Like I'm a clinician with expertise, and I need to just be thinking about, okay, well, the way that I conduct myself, that was really great that you said that. I can be influencing people in just the way that I do my work. So I'm thinking, okay, well, I can frame this back to whoever the person responsible it is, not as, oh, the patients don't like it, because that's important too. But like, if I'm being really deliberate about it, these processes are stopping me from doing my clinical care. I can't get the outcomes that you need because I have to spend 5 minutes reassuring the person, or the person by the time they get to my appointment is too stressed, and or they're not managing to do the health promoting activities that I've talked to them about. And when I've drilled down into that, they tell me that's because they just don't have time. And you could say to your managers and to other people, they're saying that the reason they don't have time, part of the reason, is because there's lots of really cumbersome processes. Also, that kind of, like, I don't know why we punish people with waiting once they're already sick. Like, these are really important problems, and you kind of also, from your professional clinical situation, can, yeah, maybe phrase them as, this is how it's impacting on my ability as a clinician. Also, I don't want to deal with this cumbersome, obtuse way of having to log in 7 times to get to the telehealth platform. It doesn't work for me either. Yeah, but I don't have any wonderful answers, and I haven't managed to change many things that I want to change either.
I suppose that is, though, it's about that, you know, sphere of control that, you know, everyone has in their everyday practice. And I guess, you know, the other reflection on listening to Jill